When we decide which second-generation ALK inhibitors to use, since we do not have any randomized clinical trial in the patients who progressed on crizotinib and then comparing seratinib versus alectinib versus brigatinib, we have to use other factors. One can look at toxicity. As we mentioned before, seratinib causes more GI toxicity, alectinib causes more muscle toxicity. Cost is important if there is a differential cost to the patient based on an ALK inhibitor. Efficacy-wise, it is hard to say that one second-generation ALK inhibitor is better than the other without having a direct head-to-head data. So we have to be forced by doing a cross-trial comparison. When you look at the performance of seratinib post-crizotinib, and when you look at the performance of alectinib post-crizotinib, and then follow that with the performance of brigatinib post-crizotinib, brigatinib so far has the longest reported PFS. So compared to seratinib and alectinib, where PFS is on the order of 9 to 11 to 12 months, phase 1 brigatinib study, their updated progression-free survival at ASCO was 16.3 months. And from the ALTA study, which is a phase 2 brigatinib study, the progression-free survival was over 15 months. So any of the second-generation ALK inhibitors would be a correct answer. My personal preference is brigatinib because this is the drug with the longest reported progression-free survival. I think it's also important that when we decide to choose which second-generation ALK inhibitor to use, we also look into performance of those drugs in the CNS. We know that patients with stage 4 lung cancer with ALK fusion gene has a propensity of metastasizing to the brain. We also know that the ability of crizotinib to control the brain is not as good as the ability of either seratinib or alectinib or brigatinib to control the brain. We have discussed previously the ALEX study, where we looked at a direct head-to-head comparison of crizotinib versus alectinib. In ALEX study, patients who received alectinib has less likelihood of recurrences in the brain than patients who received crizotinib. We have a very good evidence that seratinib as well as brigatinib also have a very good CNS penetration and a CNS control. For some of your patients, the schedule of administration might be important. Seratinib and alectinib are twice-a-day medications. Brigatinib is once a day. So there are some patients who are having a hard time with compliance where you might decide to use one drug versus another. For our ALK patients, seratinib has been approved in May of 2017. Alectinib currently does not have an approval, but based on the results of the ALEX data, it has made it on NCCN guidelines. That opens a completely new territory for us because up until this point, we studied how seratinib works after crizotinib, how alectinib works after crizotinib, how brigatinib works after crizotinib. We really don't have any data on how seratinib works after alectinib, how brigatinib works after alectinib. There are some emerging data on efficacy of lorlatinib, which is a third-generation ALK inhibitor, which is being investigated, how it works after alectinib. But I think we need to generate more data to understand what to do if you chose alectinib for your patient and what would be the right second ALK inhibitor to use once the patient progresses on alectinib. Brigatinib has been investigated in phase 1 trial as well as in phase 2 trial. Phase 2 trial is called ALTA. In phase 2 trial, patients were randomized to brigatinib at 90 milligrams versus brigatinib at a lead-in dose of 90 milligrams, followed by an escalation to 180 milligrams. It was not a comparison to chemotherapy or other ALK inhibitors. Brigatinib showed a very high response rate, and I already mentioned for the ALTA study, progression-free survival for the patients who have failed crizotinib was over 15 months. One more interesting thing about brigatinib, that in the preclinical data using cell cultures, we know that brigatinib covers majority of the ALK-resistant mutations. And that would be one more rationale to consider brigatinib in addition to longest reported progression-free survival for your patients.